bilateral capsular bag rupture and unilateral IOL subluxation following mild head trauma 18 years after phacoemulsification. A 70-year-old woman with a history of uneventful phacoemulsification and monofocal IOL implantation in both eyes 18 years ago, Acrisof SN60WF Alcon, presented with a 2-week history of vision loss in her left eye. She initially denied trauma, but later recalled experiencing mild head trauma 6 months earlier with no immediate ocular symptoms. On examination, her right eye had an intact anterior capsular hexis with the IOL in the bag, but a posterior capsule rupture extending from 2 to 7 o'clock, vitreous prolapse into the anterior chamber, and pseudophacodonesis. In the left eye, the capsular bag was subluxated nasally, with the IOL partially displaced out of the bag through a temporal equatorial rent. The capsular bag exhibited minimal fibrosis, where the optic-haptic junction had been located, but was otherwise clear, with no signs of lens epithelial cell proliferation. Pronounced pseudophacodonesis was observed, with the capsular bag IOL complex intermittently subluxating into the anterior vitreous cavity. No zonules were identifiable in the affected area. Anterior segment OCT confirmed these findings. A pars plana posterior vitrectomy was performed, along with the explantation of the capsular bag intraocular lens complex, followed by retropupillary fixation of an aphakic iris claw lens artisan, calculated for near vision to maintain the patient's accustomed monovision. On the first post-operative day, the results were excellent, with a spherical equivalent of minus 2.125 diopters in the left eye and an uncorrected near visual acuity of 20/30. The patient was very satisfied. The pathology study showed that although there was some neoformation of cortex at the equator, certain areas of the capsular bag were almost entirely devoid of crystalline lens epithelial cells and exhibited regions of capsule delamination, consistent with dead bag syndrome. Spontaneous posterior capsule and capsular bag rupture without direct ocular trauma is rare. The bilateral presentation suggests an underlying predisposition. While mild head trauma may have triggered the condition, it likely affected an already compromised capsular bag. Recently, Kolbas al. described dead bag syndrome, in which a capsular bag with minimal fibrosis or lens epithelial cell proliferation predisposes to late capsular bag intraocular lens IOL subluxation. Late onset capsular bag rupture, whether spontaneous or triggered by mild trauma, is a rare but possible complication of phacoemulsification, with dead bag syndrome potentially playing a role in these cases.